Wait, let's unpack this. Get this. Imagine a condition where someone has bones that are strangely weak and deformed, these bizarre coffee-colored patches appearing on their skin, and their body goes through puberty way, way too early.
Yeah.
These sound like three completely unrelated things, right?
You absolutely do. And that's part of the puzzle. But the fascinating thing here is they're all linked by one single random genetic event that happens, right at the beginning of life.
And that linkage brings us to the subject of this deep dive, McCune-Albright Syndrome, or MAS. We've got a stack of detailed notes here, specifically tailored for revision, that give us a really structured look at this rare and complex condition.
Yeah, and our mission today is really to dig into these notes, extract the absolute highest yield information you need, and just make it stick.
Right.
We want this deep dive to be your targeted, clear, and hopefully memorable review on MAS, helping you feel prepared.
Exactly. Think of this as your shortcut to really getting the core concepts for revision. So let's dive right in and start with the basics. What is McCune-Albright syndrome at its heart?
Okay, so it's a rare genetic disorder. But the crucial twist, the thing you have to remember for revision, is that it's not inherited from your parents.
Ah, okay.
It happens because of a random, spontaneous mutation in your body cells after conception, what we call a somatic mutation.
Somatic, meaning it happens in the body itself, not in the egg or sperm before the baby's made.
Exactly.
And the signature of this condition, the classic way it shows up, is that triad we mentioned up front.
Right. The three main components that often appear together are, first, polyostotic fibrous dysplasia.
Polyostotic.
Yeah, meaning affecting multiple bones. And fibrous dysplasia basically means areas of bone are replaced by abnormal fibrous tissue, making them weak.
Okay, so weird bones are number one.
Number two is café-au-lait skin pigmentation. These are distinctive, sort of coffee with milk-colored spots on the skin.
Got it. Skin spots.
And number three is autonomous endocrine hyperfunction. Now, this is a bit of a broad term, meaning one or more endocrine glands like ovaries, testes, thyroid, pituitary, adrenals are overactive.
Okay.
And they're producing hormones independently of the normal control signals from the brain.
And that hyperfunction can manifest in lots of ways, right?
Yeah.
Like that early puberty you mentioned, but also thyroid problems, too much growth hormone causing gigantism or acromegaly, even Cushing's syndrome if the adrenals are involved.
Absolutely. And it's worth clarifying how the bone issue fits in. Fibrous dysplasia itself can just affect one bone that's monostotic, or many bones, polyostotic, or just the bones of the skull and face, craniofacial.
Right.
MAS is a specific, more severe form where you have that polyostotic fibrous dysplasia along with the skin spots and the endocrine issues. It's linked to about maybe 3% of fibrous dysplasia cases overall.
So if you're reviewing this, the absolute core idea is that triad, abnormal bones, specific skin spots, and overactive hormones. Get those three locked in.
Definitely. Now let's connect the dots. You asked why this happens. The etiology, pathophysiology, and genetics tell one really interesting story here.
Okay, what's the root cause then?
It all traces back to a post-zygotic mutation happening after the zygote forms in the GNAS gene.
GNAS.
Yeah, GNS. This gene is critical because it encodes for the GS alpha subunit, which is a key player in how cells receive and respond to signals, particularly from hormones.
So what does this specific mutation do to that GNS protein?
It causes what's called constitutive activation of the signaling pathway it's involved in.
Constitutive activation.
You think of it like flipping a switch to on and it just getting stuck there. It's constantly sending signals downstream, even when it shouldn't be.
So those cells are just constantly stimulated, leading to abnormal activity.
Precisely. And this is the key to understanding the patchy nature of the disease, the mosaicism.
Right.
The mutation happens after the single-cell zygote has already divided a few times. So only the cells that descend from the specific cell where the mutation occurred will carry that mutation.
Which explains why it's different in different people.
Exactly. This
Yeah.
is why you might have fibrous dysplasia in one leg but not the other, or endocrine hyperfunction in the ovaries but maybe not the thyroid, or skin spots only on certain areas. It's a patchwork effect.
Wow, that mosaic pattern makes so much sense when you hear it's a post-zygotic event. And it's this single mechanism, the constitutively active GNAS protein, that drives both the abnormal bone formation, the fibrous dysplasia, and the various endocrine glands going haywire.
Exactly. So if you're trying to remember the why, the high-yield terms are GNAS gene, post-zygotic mutation, constitutive activation, and mosaicism. Those pretty much explain the whole picture.
Okay, so this is caused by a random event early on. Does that mean there are risk factors that make it more likely? Anything you could do to prevent it?
Well, simply put, no. There are no specific risk factors identified for developing MAS.
Okay.
It arises from those sporadic mutations that just happen randomly during embryonic development. It's not something that lifestyle or environmental factors influence.
Clear enough.
Yeah.
So let's talk about who gets it and how often the epidemiology.
Okay. It's rare. We're talking an estimated prevalence somewhere between, say, 1 in 100,000 and maybe 1 in 1,000 people.
Definitely not common. And is there any difference between genders?
Yes. It's noted as being more common in girls.
That's interesting. Why?
This is primarily linked to the strong association with gonadotrophin-independent precocious puberty, which is just more readily apparent in females clinically.
Makes sense. And just to circle back, because it's a key point for clarity, transmission, how is it passed on?
Again, sporadic, not inherited across generations. If you understand the post-zygotic mosaicism, you understand why it's not passed down. The mutation isn't in the germline cells, the egg or sperm.
Right. So summarizing the epidemiology, rare, a bit more common in girls, and importantly, it's not inherited.
Got it.
Okay, moving on to the clinical picture. What does this actually look like when someone has MAS? The notes really emphasize how highly variable it is.
The symptoms depend entirely on which tissues ended up with that GNAS mutation and how many of them.
Which, again, makes perfect sense because of the mosaicism we talked about. Let's run through some of those specific features you might see.
Sure. First, those café-au-lait spots. They might show up over time or be present early, often found on the neck and areas around the nose and forehead.
Okay.
A key distinguishing feature for differential diagnosis, and this is a classic exam point, is that they tend to be larger and fewer in number compared to the spots you see in neurofibromatosis. Often described as having coast of Maine irregular borders versus the smoother coast of California borders in NF1.
Good tip. Coast of Maine versus coast of California. And the bone problems, what do they look like?
Pain, deformities, and fractures are very common because the fibrous dysplasia makes the bone weak and prone to bending or breaking. Limb length inequality can occur, where one leg is longer than the other, and scoliosis, curvature of the spine, is also frequently seen.
Then there's the precocious puberty, that early sexual development. You mentioned it's often gonadotrophin independent. Can you explain that distinction again and why it's so important?
Right. So in typical puberty, the brain, specifically the pituitary gland, releases signals called gonadotrophins LH and FSH.
Yep.
These tell the ovaries or tests to start producing sex hormones. Gonadotrophin-independent puberty means the MAS mutation is directly activating the cells in the gonads, or maybe the adrenal glands, causing them to pump out hormones all by themselves, bypassing that normal brain control signal. It's like the factory just starts producing without waiting for the head office order.
That's a great analogy. And it's crucial because it totally changes how you try to treat it.
Right.
Absolutely.
What about other endocrine issues?
Well, because the GNAS pathway is involved in signaling in many endocrine glands, the mutation can cause various glands to become overactive. This could be hyperthyroidism, excess growth hormone leading to being abnormally tall as a child, gigantism, or having enlarged hands, feet, face as an adult, that's acromegaly, or Cushing's syndrome where there's too much cortisol.
Short stature is also listed as a possible feature in the notes, which might seem counterintuitive if you're thinking about growth hormone excess.
That's a good point. Why would that happen?
Well, short stature can result from several things. Severe bone deformities themselves can impact height, obviously.
Sure.
Also, that early puberty, even if it initially causes a growth spurt, leads to premature fusion of the growth plates in the bone's epiphyseal closure.
Ah, the growth plates close too early.
Exactly, meaning growth stops earlier than it should, resulting in shorter adult height.
Okay, epiphyseal closure. The ends of the bones fuse too soon. Makes sense. What about other miscellaneous features mentioned?
You can see goiters, which are enlarged thyroid glands, sometimes diabetes, and also mycomas.
Myxomas.
Yeah, mycomas are benign soft tissue tumors. They're often palpable masses, sometimes painful.
Okay. And symptoms often pop up pretty early in life.
Yeah, diagnosis is possible anywhere from birth right through adolescence, really depending on which features show up first and how severe they are.
So when you're visualizing this for revision, maybe group the symptoms by system. Skin, those specific spots. Remember the NF difference. Bone, pain, breaks, deformities. Endocrine, early puberty, note the independence, and other hormone issues like thyroid, growth hormone, and maybe other myxomas, etc.
That's a good way to structure it. Thinking about all those varied features, it naturally leads to the differential diagnosis. What else might you consider when you see some of these symptoms?
Right. If someone comes in with something that looks like one or two parts of the MAS triad, what else is on your list? What else could it be?
Exactly. Neurofibromatosis is a big one because of the café-au-lait spots, but remember that difference in number, size, and border shape.
Coast of Maine.
Right. For the bone lesions, you'd think about other types of bone growths, like maybe osteofibrous dysplasia or non-ossifying fibromas.
And the early puberty, what else causes that?
Well, idiopathic central precocious puberty is the main alternative. That's when puberty starts early for unknown reasons, but is driven by the brain signals, the gonadotropins.
Okay.
You need to differentiate that from the MAS-related gonadotrophin-independent type. You might also consider milder forms of osteogenesis imperfecta if bone fragility is the main feature. And rarely, something like an ovarian cancer needs consideration if it's a young girl presenting with hormone production causing early puberty.
So the key is to think about conditions that overlap with one or two features, and then investigate properly to figure out which one it actually is.
Spot on.
Which brings us nicely to investigations. How do you confirm the diagnosis and see what's going on?
Okay, the gold standard, the definitive test, is genetic testing. You're looking for that specific GNAS mutation in affected tissue, if possible. Blood testing can sometimes pick it up, but it might be negative because of the mosaicism.
Right, because not all cells have it.
Mm.
And to figure out how widespread the disease is, particularly in the bones.
Imaging is absolutely essential. X-rays or full-body bone scans give you a broad picture of the extent and pattern of the fibrous dysplasia. MRI scans are good for defining the extent of bony disease more precisely, especially in complex areas like the skull, and also useful for looking at endocrine glands like the pituitary if you suspect involvement there. Radionuclide bone scans can assess how active the fibrous dysplasia lesions are, how much turnover there is.
And for the hormonal piece, you definitely need to check that.
Oh, absolutely. You need hormonal testing. This involves blood tests to measure levels of various hormones like LH, FSH, estrogen, testosterone, thyroid hormones, growth hormone. Cortisol really depends on what clinical features you're seeing or suspecting.
All right.
Blood and urine tests can also measure bone turnover markers, which can be relevant with active bone disease.
Any other investigations listed in the notes?
Yes, ultrasound can be helpful for checking out soft tissue masses like those myxomas, looking for ovarian cysts that might be producing hormones or assessing thyroid nodules.
Right.
A bone biopsy is generally reserved for specific situations, mainly when there's suspicion that a rapidly growing bone lesion might have undergone malignant change, which is rare but important.
Okay.
And a fine needle aspiration or FNA biopsy might be done for evaluating enlarging thyroid nodules, again, looking for any concerning changes.
So, summing up investigations. Confirm genetically if you can, image the bones thoroughly, check the hormones based on symptoms, and do specific biopsies only if really needed for suspicion of malignancy or specific issues.
Yeah, that covers it. Once someone is diagnosed with MAS, how is it managed? What's the approach?
The notes make it very clear that the overall approach is focused primarily on managing the symptoms and complications. There's no single cure for the underlying genetic issue.
Right, you're managing the consequences. And because it affects so many different systems, bones, hormones, skin, it absolutely requires a multidisciplinary approach.
Needs a team.
Definitely. You're going to need a team including orthopedic surgeons for the bones, endocrinologists for the hormones, probably a physiotherapist to help with mobility and strength. Genetic testing and counseling might also be part of the plan for the family to understand the condition.
What about the bone disease itself? Can you actually fix the fibrous dysplasia?
This is one of the really challenging areas. The notes state there are no specific therapies currently available that directly target the fibrous dysplasia to make it go away or reverse it.
Okay, so what can you do?
Management involves encouraging physical activity within safe limits, important for bone health generally, but advising avoidance of high-impact sports that could lead to fractures. Bisphosphonates are commonly used, things like pamidronate or zoledronic acid. They don't cure the FD, but they can often help reduce bone pain and might decrease fracture rates in some people.
Okay, so bisphosphonates for pain and maybe fractures.
Yeah. And orthopedic surgery is necessary to fix fractures when they happen and sometimes to correct significant deformities that are causing pain or functional problems.
And for that gonadotrophin-independent precocious puberty. You mentioned earlier that standard GnRH therapy isn't effective.
Correct. That's a critical point because the hormone production is autonomous, happening on its own in the ovaries or tests, and not being driven by the pituitary's GnRH signals, continuous GnRH therapy, which is the standard treatment for central precocious puberty, simply won't work here.
So you can't just suppress the brain signals.
Nope. You have to use treatments that act directly on the sex hormone production or block their effects at the target tissues.
What specific treatments are mentioned for managing the puberty then?
The notes list a few options. For females, testosterone was historically used to block estrogen production, though it's less available now. Aromatase inhibitors like letrozole or anastrozole are often used. Estrogen receptor antagonists like tamoxifen or fulvestrant might also be considered. Other older options include things like medroxyprogesterone acetate. For males, treatments might include antiandrogens like spironolactone or ketoconazole, which inhibits steroid production, or again, aromatase inhibitors if there's excess estrogen from testosterone conversion.
Right. So the goal is to suppress those excess sex hormones directly and slow down or halt that premature development.
Exactly.
Okay. So for management, key takeaways are it's symptom-focused, definitely needs a team. The bone disease itself is hard to treat, but bisphosphonates can help with pain breaks and surgery for fractures, deformities, and crucially, remember GnRH agonists don't work for the puberty. You need direct hormonal blockers or inhibitors.
That's a solid summary. Looking at the long term, what's the prognosis for someone with MAS? How do things tend to play out?
Well, this varies considerably. It truly depends on how severe the features are in that individual person, which tissues are affected, how badly, and what complications develop over time.
Right, that mosaicism again leading to variability.
Yeah. Because it's a lifelong condition, with potential complications popping up, lifelong monitoring and management are typically required. The good news, according to these notes, is that MAS is generally not associated with significantly increased mortality, meaning it doesn't typically shorten lifespan itself. Although the notes do briefly mention a possible small subgroup where this might not be true, without specifying further details on who that might be.
So the main impact isn't usually on life expectancy, but more on quality of life and daily function.
Exactly. Morbidity, the impact on how you live your life, that's the big variable. It depends heavily on how severe the skeletal deformities are, the frequency of fractures, the impact of chronic pain, and how well the endocrine problems can be controlled. It can range from very mild issues causing few problems to severe limitations and deformities impacting mobility and independence.
So remember, variability, lifelong care is needed, generally not fail, but morbidity, the impact on life quality is the main concern.
Precisely. Finally, let's cover the potential complications. What kind of problems can arise from having MAS over the years?
Well, the skeletal issues themselves can lead to significant complications like severe deformities, those recurrent fractures we talked about, and pronounced scoliosis, which can affect breathing if severe.
Right, and hormonal complications.
Yeah, these can include other imbalances beyond the initial presentation, maybe issues with fertility later in life. A particularly significant complication can arise if the fibrous dysplasia affects the base of the skull.
Why is that so risky?
Because it can compress cranial nerves passing through the skull foramina. This can potentially lead to sensory deficits like vision loss if the optic nerve is compressed, or hearing impairment if the auditory nerve is involved, or other cranial nerve palsies.
That sounds serious. And complications specifically from the bone fractures themselves.
Yes, you can get things like osteomyelitis, which is a serious bone infection, especially after surgery or an open fracture. Neuropathies, meaning damage to nerves near the fracture site or from compression by deformed bone, and pseudoarthrosis.
Pseudoarthrosis.
Yeah, that's when a fracture fails to heal properly and a false joint forms instead, leading to instability and pain.
There's also an increased risk of certain cancers mentioned in the notes, which is obviously a significant potential complication.
Correct. There is a small but definite increased risk of osteosarcoma, a type of bone cancer, particularly occurring within or near areas of fibrous dysplasia. It's important to watch for rapidly increasing pain or swelling in a known lesion.
And the cancer risk.
There's also an increased risk of breast cancer noted, thought to be linked potentially to prolonged exposure to high estrogen levels due to the endocrine abnormalities in females.
We already touched on skull involvement and nerve compression, but it's a serious potential complication worth reiterating.
Yeah.
And there was a slightly ominous note about perioperative risk.
Yes, the notes mention a potential increased risk of sudden death in some patients during or after surgery. The reason isn't elaborated upon in this source material, but it's listed as a possible risk factor to be aware of in a surgical context for MAS patients, suggesting careful preoperative assessment is needed.
Okay, worth noting. And finally, metabolic issues.
Hypophosphatemic rickets can sometimes develop. This is where the kidneys lose too much phosphate, often due to FGF23 production by the fibrous dysplasia tissue.
And that causes.
This low phosphate can further weaken the bones and worsen the overall skeletal disease, contributing to rickets or osteomalacia.
Okay, so to organize the complications for review, think skeletal deformities, fractures, scoliosis, hormonal imbalances, infertility, sensory, vision hearing loss from skull FD, fracture-related problems, infection, nerve damage, pseudoarthrosis, cancer risk, osteosarcoma breast, that perioperative risk note, and metabolic issues, hypophosphatemic rickets. Highlighting those specific, less common ones like pseudoarthrosis, cranial nerve compression, and the particular cancer risks is probably key for revision.
Absolutely. And, as a final thought for you to consider as you review all this, how does a single random genetic mistake happening in just a few cells during early development manage to ripple out and cause such a complex, wide-ranging, and unpredictable set of problems throughout a person's entire life, affecting everything from their bones to their skin to their hormones?
Yeah.
It's a really powerful illustration of how sensitive those early cellular signaling pathways are and how interconnected everything is.
It really is quite profound when you think about it that way. And that brings our deep dive into McCune-Albright Syndrome to a close. We've covered everything from defining that mysterious triad and uncovering its genetic root cause, that GNAS mutation, to exploring its incredibly varied clinical presentations.
How it's diagnosed, managed symptomatically, what the long-term outlook generally is, and the potential complications you need to watch out for.
We hope taking this structured approach, pulling directly from these high-yield revision notes, makes these key points click and feel memorable for your own revision.
Absolutely. Tackling complex conditions like this, whether it's for exams or just to feel well-informed, really benefits from boiling it down to the core concepts and understanding the underlying mechanisms. So keep going over material like this.
Definitely. And for more revision materials across various topics, including loads of high-yield content structured just like this deep dive, be sure to visit PathomAsRay.com.
Yeah, great resource. And don't forget freemsra.com for valuable free resources, too. You'll find tons there to help you feel totally prepared.
Brilliant. Thanks for joining us for this deep dive.